Also presenting with us today is Dr. Michael Hill, President of MDAA Consulting. Dr. Hill worked with TeleTracking in his past role as medical director at St. Joseph Health Systems. Now, Dr. Hill is using his 30 plus years of medical training to help hospitals across North America improve hospital operations and patient experience in the ED, inpatient, and perioperative services. Just a few housekeeping rules. Note that everyone is muted and in listen-only mode. We ask that you either use the Wolva chat feature located on the right side of your screen to type your question, or you can use the raise your hand feature located at the bottom of the video. And I'll unmute your microphone. And now I'm going to turn it over to Leah and Dr. Hill. Thank you all for joining today.
Hello, everybody. I'm Leah Gary. I'm very happy to be here with Dr. Hill via Zoom. You know, we've had our bio read, so you know a little bit about us. I'm going to talk briefly about our hospital. Next slide, please. Oh. So, okay, I think we were missing a slide, but let's talk about our burning platform. This is fine. So we had a length of stay that was really very long. Oh, here we go. So Santa Rosa Memorial is located just north, about 60 miles north of San Francisco in Sonoma County, which is wine country. We're one of 3 hospitals in Santa Rosa, and our service area in Sonoma County is nearly a 500,000 people. We're a level 2 trauma center. We have trauma, stroke, and STEMI programs, and are also a regional referral center for our community. Next slide. So the burning platform is this. Although we have 287-ish licensed beds, we're really constrained with space. We have some agreements to have some beds shut down for private rooms. Some double rooms are now private rooms. We have rooms shut for isolation and behavioral health patients and other things. We have some odd little inpatient areas that are very small and not conducive to having economies to scale. And so with that, we find ourselves space constrained nearly every day with excessive boarding AD. And on top of that, we had a length of stay of about 6 days, which was way too long to meet our organizational goals and our throughput goals. We've been working with the TeleTracking capacity management suites. We had implemented a bunch of the best practices, but we're having a very difficult time getting them to stick. So what we did was really work to hardwire some of these processes and develop a business rhythm and some accountability structure. Really focusing around the anticipated day of discharge and all of the contingent discharge needs or steps to home. And then to you, Dr. Hill.
Thanks. Hello, a quick shout out to our colleagues in California from Fresno, Dignity, Los Angeles County, San Diego, and also to Florida, Texas. Looks like we also have some folks from Detroit and Tennessee, and Pittsburgh. So welcome to all of you. My name is Dr. Michael Hill. I'm an emergency physician by training, but I've spent the last 25 years trying to figure out why hospitals don't work. I'm not particularly smart, but I am a dog with a bone. And the concerns that Santa Rosa Memorial had when they contacted my firm was basically 18 months of trying to reduce length of stay without success. And generally, the issues that they have follow similar themes, but also have certain common points. And generally, we look at in terms of organizations that have these types of capacity constraints that were impacting patient experience as well as the ability to accept incoming transfers and the long ED length of stay boarding that was occurring, is really trying to look at these rather than as a simple what's the one thing that we can do, to really look at these as strategic capacity initiatives. I'm not going to luckily go through all the detail on this slide, but just so you know is that the initiatives that we focused on were an inpatient length of stay initiative, a capacity management initiative, building a leadership management skills, which is a critical component to any of these initiatives, aligning the physicians, and then an initiative on patient and family experience. And so the goal that we have when we do these types of initiatives is to introduce all 5 simultaneously. If this sounds like, well, we can't do that in an organization because we only focus on one thing at a time, I'd say yes, and that's why we're in business in terms of the idea of looking at these things strategically as opposed to as a tactical initiative. The components to discharge, and I'll describe a little bit about teletracking. And my experience with that is that I've worked with about 200 hospitals and healthcare systems on inpatient length of stay reduction initiatives across North America. And one of the things that we found was that when you've got a tool that focuses on one thing, then everything tries to get solved with that one tool. And just an example of this is that generally the initiatives that TeleTracking has in its capabilities has really been focused on day of discharge activities, which is critical, time of ND discharge order to departure, the tracking, how many minutes and hours it is since the discharge orders have been written. But the challenge is that when you look at initiatives where you're trying to focus on tomorrow discharges, that fundamentally is the wrong, it doesn't work, because really what needs to happen is you need to be looking at stuff from the day of admission and tracking those components. And so the components that, in terms of the throughput best practices that teletracking has, that make a lot of sense to us is using teletracking by charge nurses during report and daily communication to patients of anticipated date of discharge. But trying to predict next day discharges today is a losing proposition, and here's why. This is basically what I look at as the discharge enterprise. And again, good news, not going to go through all the detail on this, but basically there's key work activities based on doing this in hospital after hospital after hospital. It's become clear that there's key activities that need to occur from the day of admission through the day of discharge, and that those issues have to be tracked. So on the day of admission, certain activities need to occur, including identifying an anticipated date of discharge on the day of admission. After the day after admission, certain things occur. Daily review of the anticipated date of discharge. 3-day prior activities. 2-day prior activities. On the day prior to discharge, external communications. Afternoon physician communications. Evening shift activities. And then on the day of discharge, ancillary service availability, charge nurse prioritization, and then an MD discharge order time expectations. And then there has to be discharge monitoring. So that's really the scope of the work that needs to occur to get significant length of stay reductions. I'm talking about 1 day, 1.5 days, is you really need to frame this in this perspective. And so the business rhythm that we introduced at Santa Rosa was one that we've used repeatedly and simplifies a lot of this. It's basically a 3 times a day check-in on the patient's progress, including 2 that are led by senior leaders and a physician leader. And then formalized communications with how we communicate with the patient and their family and what goes into the components of that. We call it a sacred conversation. So and there was a couple questions that came in before we started this. I'll go through a little bit of detail of what this looks like. But the components of this are formalized and are structured. And this starts with the first part is with the physician alignment. And that really is formalizing what time does the hospitalist physically have to enter the hospital, formalizing that there's a formal handoff from the night shift. A lot of organizations, it's like, well, my pager's on at this specific time, and then I come in at a certain time. But our expectations for the hospitalists that we created here was the hospitalists need to know all of their patients, reviewed all of their labs, know the status on all of their planned discharges for today, and they meet at 8:30. And they do that with the charge nurse, case managers, and social worker, and pharmacist, and therapist. That meeting is for 15 minutes, and the plan on that is simply to go through today discharges and updating projected discharge times. If there's any other overnight changes that occurs. But that's basically a 15-minute, 8:30 to 8:45. And I could spend an entire lecture on getting hospitalists to align to a geographic unit, because that's our biggest pushback, that we push through in organizations. But that basically is we want a unit-based hospitalist associated with this. And again, this was a kicking and screaming institution. This wasn't a let's easily go through and migrate that. The next is that there's collaborative care huddles. There's two. There's one at 12 noon, between 11:30 and 1 o'clock. We go through 150 patients twice a day. This is basically by unit. Each unit brings their associated care team, as well as the physician, and it's led by a physician leader who's a hospitalist, and it rotates through, and then the administrator of the day. So the goal on this is to go through their 15 to 20 patients on that unit. During that 15-minute period, then we might go through 25 patients because there's a couple of docs that may be on that unit. And they'll go through and identify basically steps to home and barriers, like consultant hasn't gotten back to me, or we're waiting for surgery, they haven't gotten back, we're waiting for an OR to open up, whatever those barriers are identified. And then the administrator of the day takes the operational tasks and does those, and then the physician leader is the one that's responsible for medical care issues. So removal of Foley's, downgrading patients off of tele, are basically asking the physicians that during these meetings. And then we have the 3:30 to 4:30 meetings, which is basically on the unit where the hospitalist is there. And they basically do that same meeting. This is a little smaller group. Palliative care isn't there. A couple of other groups aren't there. But basically they go through and they're reviewing tomorrow's planned ADODs, any updates from today, today's planned, tomorrow ADODs, and a projected discharge time. And then after that afternoon huddle, then there's a formal conversation that the nurse has with the patient of a projected discharge time for the next day, and that's communicated to the family. So I'm sure there's like a lot of different components of that. There's more detail, obviously. But our goals is to get discharge orders by 9 a.m. and patient departure by 11 a.m. for our patients. And the first part of this is getting the discharge orders by 9 a.m. And all of you, I'm sure, have gone through initiatives trying to get that done. But the bottom line is, unless you're doing things 3 days out, 2 days out, 1 day out, afternoon prior, you can't get discharge orders by 9 a.m. So what this looks like then is a scheduled business rhythm. And let me just go through this a little bit in terms of what this looks like. As we formalize our early AM mobility, so by 7 a.m., all the curtains are open, everybody's in a chair by 7 a.m., everybody's eating meals out of bed. And so that's part of the standard that we had to introduce, because we had patients that were sleeping in their beds till 8:30 because they were tired. And so that was part of it. And then we formalized the surgery, had their interdisciplinary rounding with a charge nurse between 8 and 9. At 8:30, there was the unit hospitalist huddle. At 9 o'clock, there's an ICU intensivist meeting. And then the collaborative care huddle at noon. Then there's unit leadership rounding that was part of the building out the management infrastructure and competency. And there was 2 twice a week case manager outlier meetings, which would review any patient who's in the hospital more than 8 days is reviewed. And again, all of these we're using TeleTracking, because if you think about trying to describe 150 patients in an hour and a half, you'd have to use some type of recording tool to do that. And so that included something that we called steps to home. And steps to home were those things that identified what has to happen. This patient pain PCA has to get removed. They have to be able to tolerate meds, and their fever has to stop. So steps to home were all identified into TeleTracking, into the reports, so that everybody basically they would print the reports out, we'd come to the huddles, everybody would have that information. And then during the huddle, charge nurses would update during the meeting, would update TeleTracker with any changes based on what the hospitalist was identifying. And then at the end of the day, there's the family communication for next day planned discharge times. So this really reflects kind of, again, the whole scope of what this is. And you can see this is a 7-day-a-week operation that every day a week, everybody in the hospital does this the same. So everyone's lined up on the same process. Between 11:30 and 1:30, then We talk about today, ADOD patients, progression and obstacles, plan next day discharges with barrier identification. A lot of this is just kind of standard. One of the things that we ask the physician every day on every patient with a Foley is, can we remove the Foley today? And if they have a central line, we ask the same question, can we remove the central line? We reduce Foley utilization by 60% in terms of the number of Foley days, by 60% simply asking the physician that question every single day. Central line removal, central line days reduced by about 30%. So it was impressive to just see that a physician leader asking the physicians every day on this. And again, we had that information into TeleTracker, and I'll show you how we did that in a moment. We talked about the care collaborative rounds, again, reviewing change in patient care progression. We confirm the next day ADOD patients, any barriers to them, and a projected discharge time. Case management confirms next day transportation. And then we also ask how many patient-centered conversations do we have. And just a moment on the patient-centered conversations are basically set up as, although things can change, Mrs. Jones, right now our best guess is that you're going to be going home in 2 days. As we evaluate information over the next couple of days, we'll review that with you every day. And then that ADOD is written on the whiteboard as part of the communications to both the patient and the family. We talked about the palliative care consultation. Palliative care is involved in these, and rehab unit evaluation status is also evaluated in terms of which we have a rehab unit, which ones can we move over there. This is an example of the standard TeleTracking report, and just a couple of things on this that, and again, none of the physicians, of course, knew that this existed, but we now actually have, each physician has their own list. So we've actually set it up so they have a list that they have from their EHR, but they also have this because it has some more information, but projected discharge time, the treatment plan. Comments is where you see the STH. This is the steps to home. So on this one, PT eval, dietary consult, and then this is a COVID retest. If negative results, can go to the SNF. So again, and this is also used by the charge nurses during their report, that you don't have to say all this information. The information's there, so you're reading it, and then you can ask questions on it. So this rapidly decreases the amount of time that people historically have verbally tried to communicate information. The other thing that's been very valuable has been the ready for discharge, so RFD. So one of the questions that the physician leader will ask is there any other medical indications for this patient's continued hospitalization? If they say no, that patient is flagged as an RFD. And then that report is sent out by the nursing supervisor at the beginning of each day. You see, all of these are the following attributes that we actually have put into TeleTracking as part of the icons that when we did the build. We put in all of these components so that they're identified under the patient attributes of certain things. So I can identify, I don't have to ask every patient, do they have a Foley? I see, oh, they've got a Foley. So I'm going to ask, can we remove the Foley today? Just a brief overview of TeleTracking and what it looks like. A couple of things that are important. First was this was a new one we put in COVID status. But we have who the primary care physician is. The HS is the hospitalist, so there's 10 teams. So each hospitalist is able to get their own team report. Oxygen needs, current ambulation, fall risk, if they're a behavioral health patient, if they're on restraints, if they're a Foley catheter or central line, palliative care. So basically patient safety issues, special needs. And then the next part on this is the disposition planning, which includes projected discharge date. You notice also it's not just the date, but also the time. The evening before and the afternoon rounds is when we update all of the projected tomorrow discharge times. Case management touches TeleTracking, and they put in their case management barriers into there. This is dispositions, where the patient's going, and if there's any home health needs, if so, what type of home health needs there are. If the patient's going to a preliminary SNF, which SNF are they going to? And then this is a confirmation the day before that the SNF is ready to accept them, and then how the patient's getting transported. The F is the family icon that goes for the afternoon communication of when the family needs to arrive the next day. And then we have a variety of other disposition icons, but you get the gist of this. The key thing on this is that there's I'm gonna, 100% is too high, let's say 99.5%, is all the case managers, leadership, physician leadership, and physicians are all looking at this every day. And so you have to get to a point of where you increase your adoption rates enough so that these are valuable. But after doing this, I did the first 100 days running the meetings, and then we passed it off to the hospitalists. But after that, you get pretty good adoption rates on utilization of this. So we have rules about when the nurses are supposed to do it, what is the nurses are supposed to do, what is it that the lead nurses are supposed to do. And this is just examples of kind of, in terms of all the different components, who's filling out what with the associated icons. And what this looks like is this basically is formalizing the floor nurse responsibility for teletracking, the lead nurse responsibility, and this separate slide for the case manager responsibility. So that was like, it took us about a week to put this up. This was a fast initiative. This was 10 months of working with the organization. And I think one of the things that we always look at on this is you can design any process, but you really have to do is establish accountability. And that's where Leah comes in. Leah?
Thank you. So what you see here on the screen are these clocks, and these clocks become very important to us. And this is how we kept everybody on track regarding where they're supposed to be and when and what they're doing. And it allowed us to be very clear about what the expectations were or are, and manage to that. The other thing that's pretty interesting on the next slide when we talk more about accountability is that, and Dr. Hill mentioned it, is that the AOD actually goes to every one of these collaborative care huddles twice a day, 7 days a week, including weekends, and tracks the progress of the huddles, the integrity of the huddles, ensures that people are complying with the design process, coaching and mentoring if they're not, and then tracking how many rounds we were able to accomplish, and also removing barriers, which is very important. There's a lot of things that happen every day in the hospital that are unforeseen, and it would be very challenging for the frontline clinicians to sort of back away from their patient care activities to try to navigate, all kinds of complexity and personalities and things like that. But as the leaders, we can do that. Go ahead, next slide. So then the next question is, how did we actually do? And this is a lovely slide. So what you see in the first graph there in the kind of top left is the length of stay. And we were not quite as good as the most loosely managed, we were actually not as good, let's not kid ourselves, as the most loosely managed benchmark. And over time, actually became better than the most tightly managed benchmark. Next to that is the discharge orders by 9 a.m. graph. And we can see that we were approaching 44% towards the middle of June and July of discharge orders by 9, which is really important. It allows all those activities to get started early. And one of the mantras that Dr. Hill brought to us was unplanned work is labor-intensive work. And we really took that to home and to heart, knowing that if we don't plan ahead, we're never going to get ahead of the curve. The very bottom squiggly little graph is actually what we did with our outliers, and we had quite an improvement of all of our outliers. Our organization tracks outliers greater than 20 days. We're actually tracking in several segments, and we saw a significant decrease in all segments, including those over 20 days and between 9 and 20 days, and et cetera. So pretty happy about that. And then for a counterbalancing measure, people were always very worried. Okay, so we're going to shove them out of the hospital, we're going to get them out too quick, and we're going to have a lot of bounce backs. And in fact, we tracked that and we saw no increase in our readmission rates. So there you go. Next slide. So one of the things that we were focusing on was also our patient satisfaction. And we've had a very bumpy road with this, I have to admit. But what we did see is some upward trends in both the perception of nursing care and the patient's report of how the discharge process went. So we're still working on that. We're seeing sustained results from that. Our results are a little bit, we've changed our format a bit since we went with this process. And our numbers are quite a bit lower due to the COVID, but we are managing to continue to work on it and seeing that upward trend slowly continue to trickle up. Next slide. So the big one is always about how do you sustain something like this? And that is definitely our challenge as well. And we completely doubled down on our commitment to sustainability. Our governance team that has physicians and executive leaders on it still continues to meet regularly. Our AOD still participates and attends the collaborative care huddles 7 days a week, including weekends and holidays. We have some internal teams that are continuing to refine various processes. And when we hap upon something that maybe is starting to backslide, we quickly get it on track. We're going back and we're looking at some old things that didn't work in the past. For example, working on a discharge lounge that did not work in the past, but we're putting fresh eyeballs on it in the context of collaborative care and really looking at ways to continue to optimize this. But the bottom line is really around having that strong executive leadership, strong physician leadership, alignment with all of the ancillaries, have a defined business rhythm, and then systems of accountability. Okay, and back to you, Dr. Hill.
I think the lessons that we have, I think, from this are the same that we've had in other organizations, which is that to be really successful, you have to look at the teletracking as an enabling technology. It's not the leader. And that really, if you're looking at length of stay reduction initiatives, they're multifactorial, cross the organizational plane. And really, the most significant economic impacts in clinical care variation reduction are really centered on focusing on length of stay reductions. They really impact every single patient and impacts the way that our patients are communicated with from the day of admission through discharge. TeleTracking has a great functionality, and again, by using it to record key patient information and being able to modify it on a near real-time basis throughout the day in organized huddles really allowed the organization to create a consistency around those communications and to use that information to drive action. Thank you for your information, for your time today. I think we're ready, Latoya, for questions.
We are. So there are a few questions. First, someone asked what data drives these reviews, SIQ or CRS? And for you guys are using the standard reports for right now, using this data, and I believe you were able to kind of use that data and put into some of your own metrics, correct?
Yeah, the teletracking data that we use is the time of discharge order to departure. That data is a value. The other ones we have a standard, from the consulting firm, we have a standard dashboard set that we put into each organization that's kind of Tableau driven. But we take all of, we have just do downloads of information from the EMRs, but the teletracking information that's valuable for us is the time of MD discharge order to departure. And then obviously the transport and EVS, all the other modules as well.
Great. So our next question is asking how you're entering in all of the attributes that you were looking at before, I believe on the portal page. That's where they were referring to.
Yeah, hold on 1 second. I'll go through that. We went through that fast. They're in the tracking set. Whoops.
Mm-hmm.
Just missed it. Hold on 1 second. I think I messed that up.
So that just to expand on that.
So basically,
go ahead.
Yeah, we put them in as headers, and then you just simply click on each one of those. So this is something that the attributes, you definitely don't want to be writing them. And so you just, the patient's got a Foley, the patient's got an external condom catheter, the patient's status supposed to fall risk. So there's certain rules around who puts those in and when, but they basically just go into the system and touch each one of these columns to drop in the information. And so it makes it very easy. And again, we don't want to do a lot of writing. The writing is simply limited to the steps to home. Everything else we basically made into an icon to standardize how the information is put into the system.
So just to expand on that, they may may have a little bit more information. I'm wondering if they're asking, are any of those icons interfaced? So I know some of them can be clicked with literally just a click, which is very easy. Do you have any of those icons that are interfaced with your EMR?
Let's see. Yeah, I think this. I'm looking at these right now. Patient origin. I don't think so. Readmissions is no. Sorry. I think these are all of these are manual. I think there are some automated ones, but not on those icons.
And that's great, because one of the things I think we do hear feedback is that it's so hard to get things, the icons done, and we can see that they're doing a great job by manually clicking. Those are automatically put into the portal and you're able to click them as you go. So I think that is fantastic and a great way to show how easy that can be done. So,
yeah, let me just back up for a second there, in terms of why this is far easier to use TeleTracker to do this than an EMR. I think you know this. If just imagine that you've got 15 minutes, 25 patients, and you've got to go into an EMR and put in that there's a Foley. I mean, that's like 4 minutes. Easy. Go log into the patient, click on it. So with TeleTracking, you can go through and say, okay, yeah, these 3 new patients have Foleys. Boop, boop, boop. Great. Now you're on to the next item. So, and also you can change everything. Like disposition got changed from home to a SNF. Great. Just update all of these. So this becomes very easy for very rapid fire changes, because as you can imagine, if it's going through 3 times a day review, it's very dynamic. And so you need to have an input system the way that we have set, that way that TeleTracker is set up to be able to make that effective.
So we have one other question come in. This is from Maria. Maria is one of our nurses here at TeleTracking, and she's wonderful. So she wanted to know, how did you shift the doctor's compliance with not seeing newly admitted patients first in the morning? It's so exciting to see that these outcomes, especially getting doctors in for the discharges so early.
Yeah, I think, so here's a couple of things. You have to understand that with the hospitalists, there's a principal perspective why every single healthcare provider is doing what they're doing. And the hospitalists are basically bringing how they've been trained into this work environment. And so that's got to be respected. But at the same time, they have to understand what the organization is committed to and why we need them to make their changes. That's why we had the huddles at 8:30. We wanted to have them at 7:30, but by 8:30, they can go through and take a look at all the lab results. And if there are clinical issues that they have to do, that's fine. But basically the work rhythm is, and if you've gone through and done all your patients from yesterday, that should actually be pretty easy. I know this patient's waiting for a potassium, this patient's waiting for the results of a biopsy, this patient's waiting for this, and if they've been able to ambulate, I can get those questions answered pretty quickly, and then I can continue on with the rest of my rhythm. So it's not that we're taking 20 minutes of their day in the morning to try to figure out if their patients are ready for discharge. Everybody is already lined up. We just reviewed this 14 hours ago of what needs to happen. So the fact is that amount of time in the morning doesn't take a long period of time if you have the rest of the business rhythm lined up. The challenge that everybody's got on length of stay reduction initiatives is we try to change only one component of their work. And then they say, I can't do it because I'm doing these other things. So it's like, okay, well, let's just change all your work. Let's just change the way that all of you do your work. And that's far easier, and you get far greater results than trying to make tactical initiatives where it doesn't fit in with the rest of all the variability that's going on in the rest of the management of the patients.
Well, I wish we all had physician leaders like yourself at all of our hospitals. It looks like Maria just wanted to say that she loves your perspective. I think that is all of the questions that we have so far. Are there any additional questions that we have? And Doctor, if you want to advance the slides to the end, there's a survey
Oh,
slide.
sorry. Yeah, thank you. My bad. That's like the one thing I had to do. I didn't do it.
No, you did amazing. I'll
No, I
just, as
didn't.
you are scrolling through, I'll just ask that there's a survey at the end. We love to hear feedback, and we take that feedback and we make changes. So we really want to hear your opinion. There is a rate the session button on the bottom of your screen. And we'd love to hear from you. And we hope you can join us next year in person, I hope, at the JW Marriott in Miami, Florida next year. It's been 30 years and we want to continue the mission. So we hope you'll be able to join us. And then lastly, just make sure that you go to Knowledge Bridge. All of the presentations from the sessions at Telecon will be listed there. There's also great collaboration, lots of content. So please make sure you go to Knowledge Bridge. And lastly, I just want to thank you, Dr. Hill and Leah. Thank you so much for all of your work and everything that you do. I know it's been trying times, but I feel better knowing that you guys are in the lead there. So take care, everybody, and have a great rest of the conference.